Thanks to our excellent staff this morning for the wonderful presentations and for our attendees. Happy to take any questions. I see some start to trickle in. So if you have any questions, please post it in the chat and the Q&A. First question to Dr. Lucas. And Dr. Smith kind of mentioned how MEK inhibitor can affect the disease natural history. How do you approach this discussion with adults? As you may, get asked, well, can we be proactive and start a targeted treatment in the hope of changing the disease natural history? And, can this decrease the risk of malignant transformation? Can this prevent new tumors from growing? And in the midst of lack of data so far, how do you approach that?
Good question. Thank you, Dr. Bovitz.
Is this okay? Okay, I have the microphone. Thank you, Dr. Lopez. So I think that's a great question. And I think, like you said, we do need additional kind of long-term data to be able to better answer it. But I think the way that we approach it is less of, kind of the prior paradigm of being like a quick fix or a solution or a cure, because they aren't, but more of kind of a long-term disease control rather than, kind of taking things one by one, kind of taking the curve from kind of growth and change of specifically plexiform neurofibromas and bending it downwards and kind of keeping things as stable as we can for as long as possible. I think we don't have the evidence yet to say that there is clear prevention of things turning malignant, so malignant peripheral nerve sheath tumors. But, I think that the folks in the clinical trials that Dr. Smith highlighted as well did show that people can remain on these treatments and have durable responses for, years. So I'm hopeful for kind of the future follow-up data to answer some of these questions better.
Thank you. Thank you so much. Next question is for Dr. Guenther, and I personally learned a lot from your talk this morning, so thank you, and for all you provide to our patients. So how do you know when to wait for a nerve to heal further versus proceeding with surgery for the reanimation?
Yeah, so it depends. So yeah, if there's an injury during surgery or any other mechanism, the nerve has a kind of a time frame to recover. Typically, if the nerve has no recovery by 6 months, we don't anticipate a meaningful recovery. If it starts to recover before 6 months, then we essentially watch it through the process. Recovery after a facial nerve injury has a different kind of trajectory than what we talked about before, which is more the severe complete paralysis. And then in terms of treatment, once the healing sort of plateaus, it really comes down to when did the weakness start in terms of are the muscles viable? You have about a 12 to 18-month window to intervene to get those muscles to sort of perk back up and take a new signal. And then beyond that is when you have to do that muscle transfer procedure where you essentially restore the muscle and the nerve and sort of bypass the entire system and use a nerve as the input.
Thank you so much. Thank you. Well, follow-up question. Well, for especially adult patients that they have this for years and years and the muscles atrophied, how does this impact the surgical planning? How does this impact the healing when you transfer muscles from another part of the body?
Yeah, so once that muscle atrophies, whether it's 2 years or 20 years, it's kind of the same thought process and set of procedures. So it's, again, really you take that gracilis muscle, replace it to the face, find a new nerve, whether it's the cross face from the opposite side or the masseter nerve. You can also use the hypoglossal nerve in some cases as well. Once you get to that process, it's really the same surgery. So you're really bypassing the entire system. So even if the muscle is completely atrophied, that's when we bring that muscle up. So whether, again, it's with 2 years or 20 years or the patient's 5 or 55, it's sort of the similar concept of just bypassing the entire system with a new nerve signal.
We're very thankful for your expertise and colleagues as well. Thank you.
Thank you.
Next question for Lauren. So great talk this morning. So how do you approach kind of genetic counseling, pregnancy, and couples are trying to mitigate this as you said, it's a 50% chance to pass this to future generations. So what can we do to mitigate this risk? Thank you.
Yeah, that's a great question. And we have a lot of options available to families these days. Mainly, our approach is to first determine how the couple would use this information. You know, there's options that we have available for a process like IVF, and then we call it pre-implantation genetic testing, where after the embryo forms, when there's still very few cells there, they can pluck out one cell and test that embryo to determine if the NF1, NF2, other gene mutation is there, and then only implant embryos that do not have that mutation. Other couples just want to know, right, if their child will have NF1, not necessarily looking to change a pregnancy, go through IVF. And so we also then have the option of testing baby after baby's born. There's some tests we can do when the couple is pregnant. And so it's all really about just figuring out what question are we hoping to answer, and then guide you through which options are available to you. And thankfully, the cost of those things is coming down. You know, it's not the cheapest process in the world, but it is available.
Glad to know that. Thank you so much. Thanks, Lauren. Next question to Dr. Smith. So in the world when we have, we're thankful that we have now more than one option in terms of medical treatment for pediatric and for adults with plexiform neurofibroma. So how do you approach this discussion when you have multiple options? And on the same line is the duration of treatment. You mentioned the COMET trial. You mentioned the SPRINT trial, where the study was, the data was looked at 2 years. How do you decide in terms of length of treatment? So, thank you.
Thank you. So these are not easy, but they're just detailed conversations that I sit down and have with the family. As far as addressing which agent to start, generally it's been on dosing schedule. And for a long time, selumetinib only came in a capsule, so that was a little bit limiting for young children because they couldn't swallow pills. Now they have sprinkles, and so you can do that. But that was a determining factor for quite a long time, is the formulations, and we always run up against that in pediatrics. The other thing is looking at side effect profiles, because if you're just comparing selumetinib to mirdametinib or maybe another MEK inhibitor, since mechanistically they should work similarly, I look at side effect profiling, dosing schedules. So gomekli, you have to do just 3 weeks on and you get a week off. Selumetinib, it's twice a day, every day without a break. And so there are just dialogues that I have with the families looking at those things. And if one drug has more skin toxicity than another drug, and you're talking about a teenager, that's a really big deal because we have major compliance issues right in that population. And then what to do with kids or individuals after that 2 years of therapy. Should they come off to see if the plexiform will stay stable for a while or if it's going to regrow and reintroducing the drug? We're all facing these things. And for me, it's really been a matter of compliance with the family, toxicities that the patient is experiencing, and just monitoring them closely. And I think to the point that Dr. Lucas and you were addressing is, yeah, how long, and as we transition them to adulthood, what is this going to look like for years and years to come? I don't think anyone really knows exactly, but I address that individually with each family based on those things.
Very helpful. Thank you so much. Next question is also for you, Dr. Smith. So, for NF1 associated optic pathway glioma that responded well to the carbovincrestin, what does the long-term stability look like at 5 years, 10 years out from finishing treatment, and how do you continue monitoring these patients?
So the 5-year stability is about 50% after you complete treatment with an optic pathway glioma, having received a full course of carboplatin, vincristine, or carboplatin alone. And we continue to follow these children, throughout childhood until they become into their young adulthood. And sometimes in that setting, a child will only need one course of treatment. We follow them both with not just imaging of their brain and orbits, but also with regular ophthalmologic exams, because it's become abundantly clear that even if you have radiographic stability, which we thought for a long time was great, you can still have visual decline. And that now would be an indication to reinitiate treatment. So does that answer what you were, yeah.
Thank you so much. And probably this is the last question, Dr. Lucas. How do you approach the counseling, and also for Lauren as well, like risk of cancer and the need for monitoring in adults with neurofibromatosis?
Yeah, so thank you. That's definitely a big part of the initial conversation and discussion of diagnosis of folks with NF1, and certainly for kind of ongoing surveillance that's needed. First and foremost, it's just kind of informing people that there is an increased risk of cancer as compared to the general population, and the specific recommendations for women, in particular young women, to kind of not only stay on top of kind of regularly scheduled mammograms, but also likely get breast MRIs, have dense breast tissue that would require additional imaging. So we typically refer to our kind of high-risk breast center for those patients. And then really just making sure that we are discussing kind of red flags or warning signs of plexiform neurofibromas in adults, things like sudden growth, redness, kind of change in the appearance, and certainly kind of an increased spike in pain and related symptoms.
Yeah, and I just wanted to add that we're very lucky here at the Cleveland Clinic, where we have lots of providers in different disciplines that are very interested in learning about these different genetic conditions that increase the risk for cancer. So, we have a list of providers that specialize in genetic disorders that increase the risk for breast cancer. So like in our breast center, we have specific providers who follow our patients with NF1 to offer them those mammograms and MRIs every year between ages 30 and 50. So we keep a list of all of our providers, and if you ever need a name of someone who has experience with NF1 kind of outside your normal group of providers following you, that's something we can always help with as well.
Perfect. Thank you so much. Thank you. Thanks everyone for your valuable input, your time. Thank you.